Good morning. And,
I don't think your mic is on. Oh, it is.
It is on. I think we're good. Well, thank you all for coming out. We've convened this hearing with the Secretary of the VA to discuss a very important and expensive issue that was first presented to us last week. VA's plan to sign a contract with Cerner Corporation for an electronic health record. The record will use the same platform that DoD has purchased from Cerner for its health record. Since this need developed after the FY18 budget was submitted and before we received the FY19 budget, can you hear me?
Somebody can change. Your mic is on, so.
The VA proposes to begin funding it through a reprogramming request. We understand that you've not completed negotiations with Cerner, so there are some total cost issues you're not able to discuss in open session out of concern about generating bid protests. We intend to pursue those issues in a closed session that will follow this one. However, we're confident we can discuss the major elements of the contract in public. For veteran members of the committee like Chairman Frelinghuysen and Ranking Member Lowy, the creation of electronic health record has become a tired refrain. They've been hearing about it since the mid-1990s. VA secretaries have come and gone promising that their records were achieving interoperability, or that they were developing the same record as DoD, or that they had decided to have two different systems that would talk to each other. Now the pendulum has swung back once again to creating one record to be used by both departments, the position this committee has argued for from the start. The number of years and dollars that have been wasted reaching this point is extremely troubling. Mr. Secretary, we know that we cannot lay this past history at your feet, but you will forgive us for being a little bit skeptical that at this late date, VA has now found the answer to its electronic health record conundrum. We know you're anxious to sign the contract with Cerner, but the committee will need more information before it's comfortable with approving this first step down a long and expensive road. And before we ask you to give a statement, I'd like to inquire if Ranking Member Wasserman Schultz has any comments.
I do. Thank you, Mr. Chairman.
Please recognize.
Welcome, Secretary Shulkin. Thank you, Mr. Chairman. We do appreciate you being here on fairly short notice so that we can discuss the VA's efforts to modernize its electronic health records platform. But I really think, especially because we have some new members, including relatively new member myself, that we walk everyone through the EHR timeline thus far and the unbelievably lengthy process that this has been, even for government. Mr. Chairman, as you know, in 1998, during the Clinton administration, a presidential review directive acknowledged that the DoD and VA systems were not compatible and that action should be taken to identify data exchange systems. In 2003, President Bush established a task force to improve healthcare delivery for veterans, and it recommended that the departments develop an interoperable record. In 2007, the President's Commission on Care for America's Returning Wounded Warriors also supported interoperability, the genuine ability of these two systems to seamlessly exchange and make use of the other's information. Then in 2009, President Obama announced that DoD and VA would be working together to build a seamless system of integration. Fast forward to 2011, when VA Secretary Shinseki and DoD Secretary Gates announced plans to create a single electronic record. However, just 2 years later, in 2013, the two departments announced that they would no longer create a single common health record and instead solely focus on interoperability. The VA chose to modernize its existing VISTA health record in-house, while DoD announced it would contract a commercially produced health record. In response to that problematic announcement, the House reported fiscal year 2014 Milcon VA bill directed the VA and DoD to develop a single electronic health record. I stress, directed the VA and DoD to develop a single electronic health record. Unfortunately, the committee was forced to remove that requirement after discussions with the House Armed Services Committee. The final appropriations language permitted either a single system or two interoperable records. After that battle was lost, DoD went on to award a $9 billion contract to Cerner to develop the DoD health record, while at the same time, VA efforts to modernize VISTA underwent further review. Mr. Chairman, I believe we can agree this would not have led to genuine interoperability, and the patchwork of the joint legacy viewer has left much to be desired. Finally, earlier this summer, the VA announced its intention to award a single source contract to Cerner to provide VA the same electronic health record DoD is developing, as well as follow the same rollout cycle being operated by DoD. So, Mr. Chairman, this issue could have and should have been resolved years ago. It's no wonder that our constituents get incredibly frustrated with the insanity of the bureaucracy of many federal agencies, and this is a textbook case. When I think about the time and resources that have been wasted over the years on this endeavor, it is easy to see why members have such strong feelings and such frustration concerning this issue. And I share the chairman's recognition that it is certainly not at your feet, but it is at your predecessors' feet and people who have been working on this for probably all of those years. And while I'm pleased that the VA is moving in the direction of creating an integrated health record system finally with DoD, like we thought should happen years ago, I was not thrilled about getting a $782 million reprogramming at the end of October that needed to be acted on by November with no real details. I'm also concerned about how this new system will work with the private sector providers, and that's a question that I hope you're going to address in your testimony. If not, I'll ask you. With veterans taking advantage of community care in significant numbers, we need to ensure that the new EHR system will be able to seamlessly exchange data between the private sector and the VA. Years down the road, I hope to not be at a hearing where we're discussing our frustration over the less than complete interoperability and ability to seamlessly move electronic health records from DoD and military service all the way through, including to the private sector. So I look forward to the opportunity to hear your thoughts and share my concerns, and I yield back.
Thank the ranking member. This time I'd like to recognize the chairman of the full committee, Mr. Frelinghuysen.
Great. I want to thank Chairman Dent and Ranking Member Wasserman Schultz for scheduling this hearing, and I want to thank everybody for being here today. Dr. Shulkin, it's good to be with you and your colleagues. We're here today because of your reprogramming request for additional resources for your electronic health records project. As all of us are painfully aware, the VA and DoD electronic health record compatibility, as has been mentioned, has been an issue for over 20 years. In fact, 4 years ago, your predecessor, Rick Shinseki, and Department of Defense Secretary Chuck Hagel met with Ms. Lowy and with my predecessor, Hal Rogers, and made a fairly public commitment to sort of get the damn job done. And it was supposed to be some sort of a solution was supposed to be reached at within a year. It was never done. DoD went one way, VA went another way. Despite those decisions, Congress has supported, because we would, in a bipartisan way, the joint effort by providing billions of dollars over the years for these different projects. So when the committee was asked on short notice to approve a reprogramming to get yet another proposed project started, and one that would require many billions of dollars over a long period of time, it was clear we needed some answers. Today we need answers. True costs, what can be salvaged from the old system, and when it is all said and done, will the systems be seamless? And will this investment take away from dollars needed as well to replace existing old IT systems in the many veterans hospitals we have around the country? We have dozens of them, old systems. And will it take away from meeting the challenges of the new choice program? And may I say, a constant irritant to me, the embarrassing backlog of cases. I mean, some of these men and women are in their 80s and they're waiting for some sort of adjudication of their cases. Totally inexcusable. I know the focus here is on electronic medical records. Two priorities for the entire Appropriations Committee, not just this subcommittee, which Chairman Dent runs well, is that we ensure that we're providing the best medical care for our veterans and that we're setting out a fiscally responsible course to meet their needs. All of us want to hear in detail and for the record how that's going to be done. Thank you, Mr. Chairman.
Thank you, Chairman Frelinghuysen. At this point, I'd like to ask the Secretary to introduce his panel and then proceed with your testimony. Thank you, Mr. Chairman. Thank you, Mr. Secretary. Recognized.
Well, Chairman Frelinghuysen, Chairman Dent, Ranking Member Wasserman Schultz, and all the members of the committee, thank you for being here. And our intent is to be candid and answer all your questions this morning. I have with me to the right Scott Blackburn, who's the executive in charge of information and technology, and to my left, John Windom, the executive for the electronic health record modernization. And as you know, VA and DoD have been working on trying to get interoperable electronic medical records for quite some time. I was only able to trace the history for 17 years, but I'm going to defer to the ranking member, who I think did a much better historical record of this than I did. So we're gonna use her timeline. It's been quite a while. Chairman Dent, I think skepticism's appropriate. I don't know any other way to interpret history than to say that this has taken way too long and there have been many false starts along the way. So I'm right with you. I think that there's enough blame on both sides here with DOD and VA, so I'm not going to spend a lot of time on the history. I will tell you right now, because that's really my best chance to sort of assess the situation, I've never seen better cooperation between DOD and VA, and I have to give a lot of credit to Secretary Mattis and the Deputy Secretary Shanahan for leading this and saying we are going to get this done. So I think everyone's in agreement this has taken too long. Even besides the fact that we don't have interoperable systems, VISTA by itself is not a system. It's 130 different instances of an electronic medical record. That's insane. I mean, but that's the system that we have today. So we could continue down the same path that we are right now without DOD and VA being interoperable, with VA having 130 different electronic medical records. But we could alternatively go for a commercial off-the-shelf system that's going to provide a single system with DOD and give veterans seamless care and this integration with community providers that the ranking member mentioned. From my perspective, maintaining the status quo is just not acceptable. The health and safety of our veterans is our nation's highest priorities, among our highest priorities. On that, I know that everyone here agrees in a bipartisan way. Critical to meeting that priority is a complete and accurate veterans health record in a single common EHR system. Adopting the same EHR as DOD will vastly improve VA services and significantly enhance the coordination of care for veterans, not only at VA facilities, but also at the Department of Defense and with community providers. Continuing to pursue VISTA EHR interoperability would fall short in providing veterans the quality health care that we can give while throwing good money after bad. So on June 5th of this year, after carefully looking at the data, I announced my decision to adopt the same electronic health record as the Department of Defense. And I'm convinced adopting the same EHR system that DOD uses is the best solution. It will allow VA to keep pace with health information technology and cybersecurity improvements that VISTA simply cannot achieve. Veterans' health information will reside in a single common system providing seamless care between the Department of Defense and VA. We will be able to share veterans' health information with our community partners. And for those transitioning service members, veterans' medical records will be at VA on day one. And working hand in hand with DOD on the same system, we're going to gain the advantage of their lessons learned while making sure we fully achieve interoperability objectives. We're also committed to working with other EHR vendors besides Cerner and leading technology companies to create interoperability with our academic and community partners within the communities where our veterans live. This is the best decision for veterans in the short term and long term, and it's the best decision for taxpayers. Upgrading and maintaining VISTA to industry standards will cost approximately $19 billion over 10 years. That's an independent study that was done by Grant Thornton. And we will still not achieve the necessary VA-DOD interoperability that the new EHR system that we're proposing will provide. The new EHR system over 10 years will be billions less than the $19 billion required for our current system. We're going to discuss the specifics in closed session, as you suggested, Mr. Chairman. And by moving from over 130 instances of VISTA to a single instance of the new EHR, we will save billions more in efficiencies and quality improvements. I look forward to discussing those details as well in the closed session. But what I can say here is that we're achieving substantial discounts choosing the same system as DOD and aligning our system deployment with theirs. Mr. Chairman, we want to work with Congress to find a common solution to funding this EHR modernization plan in fiscal year 18. We prefer to fund the plan as part of the enacted 2018 Appropriations bill, as I think you do too. However, we have to do this quickly. We have achieved substantial discounts by aligning our EHR deployment and implementation with the Department of Defense's. Absent an appropriation bill by the end of the calendar year funding the plan, we ask Congress to consider approving our transfer request so we can promptly award the contract. This contingency enables VA to avoid cost increases and allows us to move forward with IT infrastructure modifications and expanding our program management office to provide the necessary oversight and manage implementation. I do ask you consider establishing a new separate appropriation account for EHR modernization costs. That way we can capture everything in one place for the sake of full transparency and accountability from our initial operating capacity to full deployment and other important decision points along the way. Mr. Chairman, the Electronic Health Record Modernization Plan is right for veterans' health care and it's right for taxpayers. It will significantly improve VA services and enhance the coordination of care at VA, DOD, and in the community. Thank you for the partnership in helping us improve how we care for our nation's veterans.
Thank you. Mr. Secretary, would you introduce your panelists with you too?
Yes. Mr. Scott Blackburn, the executive in charge of information and technology, and Captain John Windom, who's in charge of our EHR modernization.
Thank you. At this time, let's go right to questions. Mr. Secretary, could you please start by laying out for us the type of record system you're contracting for, what capabilities VA needs, and the time frame and geographic rollout you plan nationwide, and the impact it will have both financially and in terms of patient health care?
We've been working very hard to answer all those questions, and we do have a very specific timeline, project plan, objectives, and in order to do this in the most succinct and accurate way, I'm going to ask Captain Windom to respond to that.
Retired, sir.
Okay.
Appreciate the opportunity, and thank you, Mr. Chairman. Because we have a closed session forthcoming, I can speak in greater detail than a closed session, but in overall, we intend to award a 10-year contract. Within that 10 years, we anticipate deploying to the full enterprise, the full breadth of the 1,600 plus facilities and community providers that support those respective facilities. We believe that within that 10-year time frame, that is very much achievable. And following the signing of the DNF back on June 5th by Secretary Shulkin, we entered into immediate and direct negotiations with Cerner Corporation such that as part of an alpha contracting process, we're able to communicate across the table to fully assess not only their concerns for deployment, to offer them full understanding of the environment that they're going to be deploying to, and therefore we're very comfortable with a plan that deploys across the enterprise in less than 10 years. We intend to align our efforts to those of DOD today. I was fortunate enough to lead the program office for DOD that successfully acquired Cerner through a competitive acquisition. So very comfortable that I've seen both sides of the fence. I'm also very comfortable that we're leveraging the lessons learned that DOD has in their associated deployment challenges. But that alignment, that critical alignment early in the process allows us to move out more aggressively in our approach, to be more efficient in our approach, and again, to maintain the requisite configuration management over both sides, DOD and VA, that will support seamless information exchange well into the future. So hopefully I answered your question, but subject to your additional questions, I will pause.
Yeah, Mr. Windom, you said you were going to roll this out across the whole system. Geographically, what areas were you going to start?
So presently, DOD is in the Pacific Northwest. They just went live at Madigan Hospital, and they've gone live at 3 other facilities. So it's our intent to deploy also to the Pacific Northwest. It's inherent economies of scale gained by labor efficiencies. I can't speak for Cerner Corporation, and I won't delve overly into the specifics of the negotiation, but there's clearly, by us deploying into the same geographical area, we'll be able to leverage the resources that are already in that area. If we deployed east, clearly they would have to stand up a full team that would have to, again, support our deployment on the opposite part of the country that DOD is in fact deploying. So we believe and have seen, as part of the negotiation process, substantial efficiencies in that area and in that strategy.
Okay, and then back to Secretary Shulkin. Your reprogramming proposes to move funding in two ways, from medical services and medical support and compliance to jumpstart the program, with appropriated funding first assumed for FY19. The first wave of transfers is $324 million from medical services and $50 million from headquarters staff hiring. We understand the hiring freeze is generated to $50 million, but the $324 million from medical services will be a hard sell outside to these outside organizations, some of whom are probably represented here today. I know you say it's for medical equipment purchases that can be recouped at the end of the year, but your FY18 budget already starts out with a $245 million cut to medical equipment. So merely getting back to the original cut level isn't particularly reassuring. How are you going to characterize this publicly?
Well, first of all, we would prefer to take the strategy that I believe that you would also support, which is not to do this transfer, but to get the 2018 appropriations done before the end of the calendar year. We are in somewhat of a time crunch in that in order for us to achieve the efficiencies that Mr. Windom just talked about, we do need to align closely with the DoD implementation. And so we're trying to do the best thing for taxpayers here. What we've proposed is an alternative if we're not able to get the 2018 appropriations bill done, where we would use some money that was from carryover from 2017 as a stopgap to be able to start this project, and then we would refund it, we'd replenish that money. So we do not believe that this will end up delaying or hurting veterans' health care, but it's not our preferred strategy.
Thank you. I have additional questions, but we have a lot of members here, so I want to go right to their questions. Ranking Member Debbie Wasserman-Schultz is recognized for 5 minutes.
Thank you, Mr. Chairman. The frustrating thing here is that the VA, and I say VA, not you, but the VA's foot dragging and missteps have become our emergency. And because DoD has jumped ahead and gone forward with what we should have been doing in parallel. That's really, as an appropriator for a long time, that's not really the fiscally responsible way to deal with things. So I just will express that frustration out loud. To follow up on the chairman's question, I was going to ask this in closed session, but since you were able to answer it in the open, I'll ask it. At the locations where the VA missed the opportunity to piggyback on DoD, are you going to deploy at those sites last, or is a second Cerner team going to have to go to those sites?
Well, we don't think we've missed any yet. They're just now implementing in the Pacific Northwest. I think they had their opening 2 weeks ago, or recognition of that today maybe is their official. So that's why we are trying to do this quickly, and we recognize you've been extraordinarily responsive in trying to keep up with that timeline. But we haven't missed any sites yet, and so we don't want to be in the position of having to go back and correct for that.
On the on the time frame to fully deploy the Cerner system, theirs is a 15-month deployment schedule per location. Is that a time frame that's set in stone, or are you going to be able to shorten it as you learn best practices?
Yeah. Working with DoD and the fact that they've been so generous in sharing their lessons and their implementation plans, we can clearly shorten this. The DoD healthcare system is 1/3 the size of VA. So let's just from the start say ours is a much more complex and larger implementation. But we believe that if the contract is signed, that we will be implementing our first site within 18 months, and then it will be this 7 to 8 year rollout that will get you to the full 10-year period. But we have to implement much faster and more aggressively than DoD, just because the number of facilities that we have are 2/3 more than what they have.
When I got on the Appropriations Committee, I inherited, as the then chair of the Ledge Branch Subcommittee, helping to bring in for a landing the really unbelievably blown timeline and cost of the CVC. So at a certain point, we had to bring in GAO to manage the completion of it so that we could stop the bleeding. So I have a little experience in oversight of something this significant, which concerns me. Just to use an example of the question I'm going to ask you, my husband for years, I'm almost always late. My husband will be early to his funeral. And in our 27-year marriage, he has told me, Debbie, it's just better to tell me the real time you're going to be here than to give me a time that's a lot sooner than you really likely are going to arrive. So that begs the question, it took DOD 26 months from generation until contract award, and you have a faster timeline than DOD and a larger system. So is there any concern that your timeline is too aggressive?
Well, first of all, I think your example is a good example we can all understand. But there is no doubt that we are being aggressive with this. But we're also doing business differently, and we're trying to do business differently. Now, that doesn't assure that we're going to be 100% successful at this, but I think the right thing to do in this situation is to act with urgency and to be aggressive and to establish sharp timelines. The major difference that we're going to do in implementing this versus other VA IT projects, which does not have a great history of on time, on cost, and we understand that, is we first of all have given up on the idea that we're going to be doing software development ourselves. That was the initial plan, which is that we're going to buy commercial off-the-shelf systems and we're going to rely upon industry partners who have good track records. Secondly, we're going to do the governance of this project and the oversight of this project directly out of the Secretary's office. That has not been done before. Part of the root cause of some of our problems at VA has been the silos between IT and the health system. And so this is going to report directly to the Deputy Secretary, who will have oversight, and there will be a new governance committee established that will have VHA and IT working as part of that governance structure. Third is we are using the lessons from DOD. If they weren't talking to us and sharing this, I'd be much more concerned. But they are so fully committed to our success that I believe that saves a lot of time and a lot of money for taxpayers. And fourth, we're taking advantage of the private sector CIOs. Mr. Blackburn's going to be on a call with 5 of the leading CIOs in the country, getting their advice, asking what mistakes are likely to happen, and essentially using private sector input. I've been a private sector CEO. I've done EHR implementations. It doesn't mean I've done anything like this or this complicated. Nobody has. But I think we're committed to working with the private sector and DOD in ways that VA before just hasn't been willing to do.
Mr. Chairman, Mr. Secretary, I look forward to being surprised. Thank you. I yield back.
This time I'd like to recognize Chairman of the full committee, Mr. Frelinghuysen, for 5 minutes.
We're admiring of the work you're doing and the fact you're putting your shoulder to the wheel. Just let's say for the record, the House did all of its 12 appropriations bills. We're waiting on the Senate. And the first bill out of the hopper was this bill.
Yes.
And may I say for the record, no disagreement, we forward funded the VA. No one else gets that, and we do it for a reason. The issue here is that we're about to approve a reprogramming of a certain amount, which commits us to a long-term obligation. And that's why we're here, just to have some assurances that we know where we're going here. That's really why we're sort of having this hearing here. For me, just a couple of comments. Is there anything, you don't have to respond, salvageable from what we've already invested in, which I have indications there is, and we have other financial systems, I'm not sure how to describe them, in a variety of VA facilities that are subpar, ancient, all different.
Yep.
And I assume you feel that those are systems that need to be replaced, rejuvenated, and whatever. But now the issue here is we signed on the dotted line with this reprogramming. We are committing this Congress and future Congresses to the implementation of this plan. And I don't need a reaction to it. Just right. we want to head in the right direction.
Right, right. I think that Mr. Chairman, you are absolutely correct in all of your comments here and your perspective on this. VA has always shared the goal of getting interoperability and has shared the goal of getting to one instance instead of 130 of our EMR. It's just that we thought we would build this ourselves. And so we've been trying to be a software development company, and we have literally spent billions of taxpayer dollars and lots of years and haven't gotten there. And what we're saying now is that we're going to go to commercial off-the-shelf technology. But what we've worked on isn't completely wasted. We have a lot that we have achieved that we are going to use in this implementation. Part of why gives us a little bit more confidence that we will get there and that we can make up on some of these timelines, because a lot of the work that we've done in process mapping of getting towards a single instance, which we had a called Vista Evolution, is not going to be wasted, and we're going to need that. We're also going to be running our Vista system in parallel while we bring up Cerner, because we cannot afford to let any veterans' health care fall down.
I'd like to recognize the gentleman from Georgia, Mr. Bishop, for 5 minutes.
Thank you very much. Let me welcome you, Mr. Secretary, Mr. Blackburn, Mr. Windom. Let me get right to the point. As you know, the issue of creating a fully interoperable health record for our veterans has been a concern of Congress for a long, long time. It's my understanding that the proposal from Cerner is focused on DoD-VA interoperability, but that the strategy to connect community physicians who provide care for veterans is not yet defined. Given the growth of the choice in the community care program, this challenge is something that really needs to be addressed immediately, particularly in rural areas. I, for one, would be much greater reassured if we knew that you had plans to address the interoperability with the community providers, as well as to ensure that all veterans can benefit from the interoperability. As such, what provisions are in the Cerner contract that will develop interoperability solutions to improve connectivity between the providers and the community? And by that, I don't mean a joint legacy viewer.
Yes, yeah. I'll get to you in a second, John. Your question is absolutely the critical question that we have set forth to achieve. So, first of all, we will achieve DoD interoperability. That's one piece of it. We will achieve better interoperability among the 130 different instances, because I practice in the VA. I have to leave my system that I use to go into one across the country. So it's not even in the VA system, true, easy interoperability. VA already has several hundred health information exchanges with community providers. So we are doing interoperability with our community providers in the network. As you know, 1/3 of our care is now out in the community. Right. So we're going to already have that. Cerner itself has an interoperability tool that connects with thousands of additional providers with standards that are common. So we will have that. But we absolutely need to engage other IT vendors, other EHR vendors besides Cerner, in order to achieve what the objective that you've laid out. And that is a program that we've just put out a RFI for to industry to ask how we can best do this and work with them to achieve the goal you've stated. We call it the digital health platform. It is an essential component of achieving the goal that we need for our veterans, which is interoperability with community partners. And we're going to be working with industry to get that done.
One of the real challenges, particularly in this day and time, is going to be the cybersecurity aspects of the community choice program connectivity, as well as the DoD-VA operability.
Yes.
So that's going to be a real challenge, and we'll be very interested to know how you're going to make that happen. You mentioned that the electronic health record program will be run out of your office. Will you set up a new sub-office? Will we see this in the FY19 request, or is you going to try to do it?
This is all part of the overall program cost. And Scott, you may want to talk about the PMO and how we're going to do this.
Absolutely. So there will be a separate office that is currently being led by Mr. Windom. So it'll be a program management office that will be made up of both clinicians from VHA as well as technologists from OINT. We feel it's incredibly important to put them together in one team, one integrated team that is working together with a joint governance structure over that includes the CIO, that includes the Undersecretary of Health, and the Deputy Secretary.
Quickly, let me ask you, where you have these CIOs working together for key decision points that might impact both departments, who will serve as a responsible personnel that's accountable? DOD, VA, who's going to be ultimately responsible for making that decision? Those decisions, I should say.
I'll defer to Mr. Windom on the joint governance structure.
We believe that governance is a critical part. We want to stay on converging paths to seamless care, not diverging paths. So governance has been something we've been working hand in hand with our DOD counterparts on, and we've created an interagency governance board. That interagency governance board is chaired at the highest levels. We like to think that much of the decision-making and results it'll be chaired at the DepSec level for us, and it's at the ATNL level for DOD. And so that board, there'll be technical and functional governance elements under those levels that hopefully most problems will be resolved at. There will be participation by Cerner Corporation as a non-voting member because they're the developer of the software. DOD, as you know, has Leidos as a prime contractor, so they'll be a participant. So it's important that we all stay in tune to the changes that each side is making or desires to make, DOD, VA, with a clear understanding that we will manage in a configuration management schema those changes, because typically most changes are good for both sides of the enterprise, not for a single side. But so sir, that construct under that interagency platform is going to be how we're going to ensure that we stay aligned in our methodologies and moving forward.
I'd like to recognize Mr. Jenkins for 5 minutes. Oh, I'm sorry, you haven't. I'm sorry.
Thank you. All good? Thank you, Mr. Chairman. Folks, thanks for being with us. Two areas of inquiry. One, we are amidst nationally and certainly at ground zero an opioid crisis, and I appreciate the work that the VA is doing trying to address this within our veterans population. We obviously have a patchwork of prescription drug monitoring programs at the state level around the country. We've had issues about trying to make sure the VA is sharing information for these PDMPs, and also that the healthcare providers at the VA have full access to the appropriate medical history for best prescribing practices. Can you reassure me about the interoperability of this system being able to integrate the information from state PDMPs, and what the status is on the VA sharing information the other direction with state PDMPs about prescribing issues?
Yeah. Well, first of all, as you know, the VA is fully committed to complying with the state regulations and the state laws, and we do. That is our current policy, that we use the PDMPs, and it is part of our multifaceted approach to reducing opioid use. And one of the reasons why we have a 36% reduction in opioid use among veterans in the past since 2010. We are concerned about data that shows that when veterans leave the VA out into the community, that there are actually higher rates of opioid abuse happening out in the community. So this is one of the reasons why this interoperability with community providers is absolutely key to us. But Cerner Corporation in this contract is committed to complying with the state regulations, And that's something that we just won't see any misstep from in the transition.
Thank you. The second, I'm a big believer that you have to be able to walk before you run, and I know what you're describing here is running with an integrated system, working with community partners, but I still remain very concerned about the existing system and the breakdowns. Let me just give you an example. I was in my hometown, Cabell Huntington Hospital, one of the largest hospitals in the state. Many veterans get care there, coupled also with our wonderful VA Medical Center in Huntington. But in my meeting with Cabell Huntington Hospital, they were sending claims for the direct VA care to Mountain Home VA Health Center in Tennessee. And they were having a 40% rejection rate just because the folks at Mountain Home VA Health Center, as I understand it generally, maybe not in every case, was sending them to the wrong VA center. So Cabell Huntington Hospital has to start stamping each claim that they submit to say where Mountain Home needs to know that it needs to be sent. And they're improved there at the 25 or 30% level. And then when Cabell Huntington tries to call, very often nobody answers. There's no ability to leave a message. So fundamentally, I still think we have serious payment system problems. We have an administrative challenge to be polite about it, because this is to the tune for a community of 50,000 people, a hospital. They've got accounts receivable to the tune of $7+ million waiting for payment. That impacts healthcare delivery for our veterans. So what assurances can you provide that while we are thinking visionarily about this new integrated EMR EHR system, but we are still making a commitment to getting the payments done in a timely, accurate fashion and addressing the flaws in the existing system?
Yeah. You know, I come from the world of running hospitals, and I fundamentally believe that if you deliver a service, you need to be paid for that. And the VA, in too many cases, as you're saying, is falling short on that. There's, again, enough blame for this to go around. We have had problems with our third-party administrators in some cases, our contractors and payments, but clearly a lot of the responsibility is also on the VA. We are working very hard to improve those areas of communication. That what you're describing is unacceptable. We are trying to build timely payment standards into new choice legislation that we hope that you'll soon have an opportunity to consider. And we're trying to simplify the payment systems, which right now require 100% adjudication, which is not an industry standard. You wouldn't find that in the private sector. So I think that we are trying to move much more to where the private sector has gotten to on timely payments, and we need to do that. And I'd be glad to look into your particular situation there so that we could get that corrected as well.
Thank you, Mr. Secretary.
I'd like to recognize the gentlelady from California, Ms. Lee.
Thank you, Mr. Chairman. Welcome, all of you, and thank you for being here. Of course, this is a sole source contract, 10 years. You've been very aggressive in response to Congresswoman Wasserman Schultz in terms of getting this done. Now, Small Business Administration negotiates prime and subcontracting goals with each federal agency. Okay, so given this contract, given that it's been pending, as we know, this work has been pending for many, many years, let me ask you a couple of questions just about this in terms of the VA. Now, I know the VA got a passing grade of B on the prime subcontracting goals of 30% of small business eligible contracts. That's the VA. Now, your newly negotiated goal for fiscal 17, actually that's been downgraded, I don't know why, to only 28%. Now, the VA notes in your report that providing timely patient care requires that we continue to rely on national regional contracts for procuring health care outside the VA system, but that the VA will seek subcontracting opportunities for small business. Now, the VA did exceed its general small business subcontracting goal of 70%, but you failed in all these other categories that are in statute. Let me give them to you. Okay, you required 5% of all prime subcontracting goals. You reached 2.2% for women. For small disadvantaged businesses, 5% of all prime and subcontracting awards. You got to 1.4%. And let me remind you, this is where the minority-owned businesses are. Okay, African American, Latino, Asian Pacific American, 1.4% total. That's outrageous. Service disabled veteran-owned businesses, 3% of all prime and subcontract. You got to 0.30%. And for hub zones, you have a requirement of 3%. You got to 0.50. Now, given the enormous amount of money CERN is going to make off of the taxpayers in this VA contract, let me ask you what you have required of them to comply with federal law to meet all of these goals, because I haven't, because what you're doing, you're going backwards now in terms of most of these businesses that you should be requiring the subcontracting goals, contractors to reach. So let me hear your thinking on that, and what are you doing about this Cerner Corporation subcontracting goals?
Yeah, so you're asking about what requirements have we put on Cerner to subcontract with small business and some of the particular...
Yeah, in compliance with the law.
Yes, yeah. Do you have it?
Ma'am, within the terms and conditions of the contract, the VA small business goals are fully captured. I can't cite those for you directly. I can get back to you with those numbers, but I could tell you exactly what percentages are going to
for Cerner, you're talking about now for this contract? Yeah, okay, for small business, okay, but for, okay.
And Cerner's fully on board with those. They have to provide, as part of the process, a small business plan on how they're going to achieve those goals.
Right.
It's really the enforcement of those terms and conditions that are important.
Yeah.
My program management office will be enforcing those goals rigidly. I can't speak for the other elements of the VA. That's all new information to me, but I can assure you that in overseeing the Cerner contract, those small business objectives will be of the foremost importance to us to achieve.
But Mr. Windom,
yes, ma'am.
Small business goals are one. You're not aware of minority-owned business goals?
I'm absolutely aware of
Then what are they, and what have you required of Cerner for women-owned businesses and minority-owned businesses in this contract?
Now, the way the contract is broken down, again, I can't cite the specific percentages, but each one of those categories have a percentage of the total contract value that they're entitled to be awarded as part of contracted work subcontracted to Cerner.
Does anybody have those requirements here?
I can get back to you, ma'am. I don't want to cite inaccurate, but I can give you those percentages broken out by categories. Have you requested? That's no problem. A matter of fact, I may even be able to get it in time during the closed session.
Thank you. And Mr. Secretary, let me just ask you, just overall, generally, what's going on over there? I mean, you know, we're trying to ensure parity and equal opportunity and non-discrimination, and here you have 1.4% this year for minority-owned companies?
Well, first of all, we are committed to this. Those are numbers that are different numbers that I have. So I'd like the opportunity to be able to sit down with you and.
This was from the Department of Veterans Affairs, your procurement division.
In what time period?
This is February. We requested it for February 2017. Subcontracting data as of March 14, 2017, for fiscal 2016.
As I said, those are different numbers that I've seen. As you know, the Kingdomware decision has completely change the approach that the Department of Veteran Affairs is doing for contracting with small businesses. And we've had a strategic pause and have relaunched to be able to meet these objectives. I think this is a goal that we share, we take seriously. As you said, our overall goals are always above our targets here. And if we're falling short in some areas, I want to make sure that you and I have the same information, but I can tell you we are going to be committed to improvements. If the data that I have is different than what you have, then I want you to have that information as well, too.
Okay, thank you, and I look forward to getting the specific on Cerner. Thank you.
Okay, Mr. Taylor is recognized for 5 minutes.
Maybe.
Thank you, Mr. Chairman, and Mr. Secretary, thanks for being here. Let me first say, number one, just like let me echo some of my colleagues' comments talking about how long it's taken. And I just appreciate that you're a hard charger, that you're aggressively moving to get the damn thing done, because it's inexcusable, in my opinion, how it's been before you and I both got here. So, but I appreciate that you're doing that. But we do have some questions, of course, on some of the savings, cost savings, and timeline stuff. But I do want to address one thing that I just heard. I think is important. Sure, it's extremely important for the VA to meet statute, to meet goals in terms of service-disabled veterans and minority and women-owned businesses and stuff like that. I'm curious what their own goals are. But at the same time, I don't want forced equality on unequal things in terms of understanding that those statute and goals are overall in the VA department. So if there's a specific contract that there aren't qualified folks that can do the work, if we force that to happen, then you're hurting veterans. So I definitely want to say that for the record. That's not something that I want to see happen. So, but I do, of course, like my colleagues, want you guys to meet your goals and statute. That being said, couple quick things. Let's see. Let's say you weren't able to get this reprogrammed, this monies. How would that affect you? What would the timeline be? What would the cost be? Would it be a complete stop for your efforts?
Yeah, we think it will. We think it will add, and Mr. Windom, please correct me if I'm not being as accurate, because we want to be fully transparent in as we can in open session. We think it will add at least 5% to the total project cost if we miss that alignment with the Department of Defense. How did I do?
You did well, sir.
Okay.
On that was good. So on the alignment, so it would seem that they're actually getting the best efficiency, the DoD, as opposed to you guys, because you're you're much bigger and you're more complex, which is fine. That's great. We want to make sure that you guys are there. In terms of if you didn't have the DoD in this, what would that also be in terms of cost and timeline?
Well, it would be a longer timeline and more expensive.
No question. Question.
I mean, we'd be glad in closed session, Congressman, we'd be glad to share with you what we believe we've been able to negotiate in terms of efficiencies. I do believe we have achieved substantial savings in efficiencies and timelines because of DoD's experience here. And we've also learned from them what they would do if they could do it over again, so that we're not making the same mistakes, which are costly to make mistakes.
When you're speaking about your community partners, which in my area I know that you do have that. You do have some exchanging information there. Is that going to be another appropriation to make sure? Obviously, CERTA has 27,000 facilities that use their information. Is that an easy fix to be able to talk to community partners and everything, or is that something that you'll come back to us and ask for more money for?
Yeah, we can absolutely take advantage of the health information exchanges that already exist within VA. We have 700 of them. We can absolutely, and it's built into the contract, take advantage of Cerner's interoperability with community partners. This digital veterans platform, which is to seek outside industry to help us create the true interoperability that, frankly, everybody in healthcare is looking for. This isn't just a VA issue. We think VA and DoD can lead this for the country. That digital veteran platform, right now we're just going out and asking an RFI, a request for information, that will turn into an RFP for outside industry help. And so we don't anticipate, we are not asking for an appropriation for that for several reasons. We don't anticipate that happening in these next couple fiscal years, and the work that does happen will be funded internally at VA. But also, healthcare technology is changing so rapidly, and there are so many new advances that we don't exactly know what that's going to look like.
Will this system allow for you to be, that we're not building on legacy systems and MS-DOS and all that stuff, but
it automatically includes the new advances, the new updates.
With software that just changes
Absolutely.
Really quickly.
That's part of this. That's part of this contract negotiation.
Can you guarantee 100% after this change, if we reprogram these funds, that you will speak to DoD, or that the interoperability will be 100%? DoD and VA.
I don't think I've ever guaranteed anything 100%, but Mr. Windom's willing to.
I mean,
yes.
He's been shaking his head over there.
I am willing to say that, because we will be on the same Cerner Millennium platform. We will be hosting our data in the same hosted facility. We will communicate seamlessly across the respective DoD and VA environments because of those reasons. So I expect it to be 100%, and I'm a veteran, so I'm banking on it.
All right. Thank you, Mr. Secretary. Thank you, Mr. Chairman.
I'd like to recognize the gentleman from Ohio, Mr. Ryan, for 5 minutes.
Thank you, Mr. Chairman. Appreciate it. Thank you, Mr. Secretary. Thank you for your service, gentlemen. We appreciate you and all the work that you do. I come from Ohio, and we have, as you know, an opiate epidemic that is of immense proportions for us. In 2016, we lost 4,000 of our fellow citizens in the state of Ohio to overdose, primarily from opiates. As you know, in 2016, we lost over 60,000 people across the country to overdose deaths, more than we lost in the Vietnam War. So this is something that we continue to struggle to deal with. And I know, Mr. Secretary, that we've talked about this before. Last month, I noticed that another substantiated report was released by the VA Office of Inspector General following a confidential complaint that the VA clinic in Baltimore, Maryland, was failing to provide appropriate quality control through the opioid treatment program. A 2014 investigation revealed a disturbing lack of attention on opioid management. Only 6.4% of new patients were prescribed opioids in accordance with the clinical practice guidelines. For our highest risk veterans, those with active substance use diseases prescribed opioids for more than 90 days, less than 19% received appropriate testing and therapy, with some clinics providing no testing and therapy at all. The death rate from opiate overdose among the VA is almost double the national average, and issues span many, many facilities. Further complicating the opioid overprescription problem is a lack of appropriate software in our clinics. As we discuss electronic records and electronic health record management, now is the right time to also address including appropriate software to provide opioid oversight. What's the VA doing nationwide and in communities like mine in Ohio to implement technology solutions to assist clinicians in delivering improved and preventative patient care so that opioid prescriptions and other medication are properly prescribed?
Well, we share, Congressman, your absolute concern and believe that although we've begun to really focus on opioid safety in 2010, that we need to do much more on this. And so I've personally participated in the President's Commission for Opioid Reduction and Addiction, and we are going to redouble all of our efforts. So when we find situations like the IG did in Baltimore in 2014, that was really a call to doing more in terms of oversight and action. In terms of technology, we have something called the Opioid Safety Initiative that has a dashboard. We can track opioid prescribing not only by facility, by clinic, by provider, and that triggers for us the ability to go in and intervene with the provider using academic detailing, which is education by our pharmacists and by other subject matter experts. By developing alternatives to prescribing medication, we adhere to the step care management approach, the DoD VA guidelines that do not go first to opioids but look for alternatives. We are investing heavily in complementary or integrative medicine approaches as alternatives in pain management. But as you know, 50% of the people we care for in the VA system complain of chronic pain. So this is a very tough population to get their pain level correctly, and simply not prescribing is not always the best answer either. So we're working on this. We are using technology. It is going to be built into the work that we've done, built into a new electronic health record, and we're gonna stick at this and actually, I hope, be one of the leaders in this in the country to try to solve this problem.
So are you seeing steps in the right direction when you're looking at, only 19% receive the appropriate testing and therapy?
Yeah.
These are high-risk populations, as you know, and they are in a lot of pain. So it's
those are referring to urine tests for concomitant benzodiazepine use. Again, something that we think is a risk. when you put a patient on both an opioid and a benzodiazepine, and being able to track those urine tests to make sure that there's not other drugs being used. That's part of the the state prescription data monitoring program as well. So this is really a very multifaceted program. 19%, of course, is not anywhere near what's acceptable. If you went back to Baltimore today, that was 3 years ago, you would find much higher rates, and we do have the ability to track this now. That's how the IG was able to find those rates. I've recently been to facilities in Cleveland. We actually brought the entire commission, Governor Christie and Congressman Kennedy and others there to Cleveland, because they are one of the leaders in the country in the lowest rates of opioid prescribing. So we're taking those best practices from Ohio and spreading them throughout the country.
You talked about step care management approach. Can you just walk us through for 30 seconds, if you can indulge me, Mr. Chairman, of what those steps are? Because I think that's an important point that we kind of ignore. The default position, give the scripts. There are these other approaches. Can you talk to us a little bit about what those are?
First of all of our step care protocols and our VA DoD guidelines for pain management are all publicly available. So we share these freely with anybody who wants to, because we think they're very good work. But what it basically says, as a prescribing doctor, and as you know, I'm a practicing physician, you do not start with reaching for your prescription pad or now your computer mouse and prescribing opioids. That you take people through what would be a reasonable approach for pain management, starting with the least addictive options and often non-pharmacologic options if that's appropriate. One of the recommendations that has come out nationally, and you've seen CVS actually take a lead in this, is not prescribing a month's worth of drug, but really 7 days worth of drug. And then, so that part of the problem of addiction is not even to the person you prescribe in, but they put the remaining drugs in their medicine cabinets and their kids get them, or somebody else in the family gets them. So there are so many things that we can do with this step care approach of how you adequately get to a point where you would prescribe opioids.
Using acupuncture, what are the are we going to have another round, Mr. Chairman?
Yeah, we're going to go into closed session.
I'll get you next round. Thanks.
You're already 2 minutes into that round, by the way. Right.
I yield to the gentleman from
Mr.
Arkansas.
Womack is recognized for 5 minutes.
Thank you. Mr. Secretary, gentlemen, thank you for being here. I'm from Arkansas, and I know sometimes we're stereotypically slow. We've been doing this, in your testimony, you talked about how we've been in this discussion now for 17 years, how we've been trying to address this issue, not you guys, because you haven't been doing it that long. And I commend you for the decision to go to the platform. It just would seem to me that that was a decision that should have been made a long time ago. And I make this observation not because of the money that we've spent and the difficulty getting this interoperability, as we call it, but because it just makes absolute sense to me that if you're going to want to talk to DOD, if VA and DOD are going to talk together, they should be on the same platform. Am I missing something as to why we have been in this rut now for 17 years?
I think it is important to understand why this has happened, because what it says is it's at risk of happening again. In 2011, on March 5th, 2011, Secretary Shinseki and Secretary Gates, I believe it was, committed, probably in a hearing room like this, that they were going to do it. And I believe that they meant that. And then what happened is secretaries change and Congress changes, and all of a sudden people say, nope, we're going to go a different direction. So I think what's important is, if we get your support in moving forward, that we do not allow that to happen, that we stay, because this is the right decision. This is the right thing for veterans. And so we have to stick at this. And it's going to be hard, and there's going to be stumbles. That's why I never say 100%. But this is something that we have to get done for the country. And frankly, the fact that we're following DOD on this gives me greater assurance that we can get this done.
The only experience I have in anything along this line on a much obviously much smaller scale, was I was a mayor once upon a time, and our court system had a bad computer system, and they went to a new system, which was fine, but they made one real major error, and that is they scrapped the old when they transitioned.
Right.
It wasn't much of a transition, but they just scrapped the old. So in your testimony, you talked about keeping the Vista system alive. What does that mean?
Yep.
And how long can we expect that we have two systems kind of running simultaneously?
So we have 130 Vista systems. Part of what we're planning on doing is we will shut them down one at a time. When we have a successful Cerner implementation and we're confident we can shut that one down, start to save some money. But by the time we get to the very last medical center at the end of this full 8-year implementation after we start, that will be when we can finally turn off the system. And by the way, even then, I think there are 37 subsystems that we haven't figured out yet how to transition off of Vista. Now, we're working on that. But we are planning on running a dual system for the foreseeable future because we don't want to have what happened to your court system. I mean, we can't afford to put veterans' health at risk.
Absolutely. And then finally, Mr. Secretary, you've been to my district, and you know how interested I am in seeing that our federal bureaucracy learn best management practices from the private sector. You've personally been to my district to witness that, talk with people. In the testimony earlier, and I think it was Mr. Blackburn that talked about, I kind of look at it as third-party validation. It's you have some kind of a CIO board, people from outside the universe that are going to be looking at the process that we're implementing this this Cerner platform. Are you at liberty to say who these people are? Do they have a connection to Cerner? Is there some kind of is there any potential for for a conflict of interest in that regard?
From what I've seen, I think the whole American medical community that I have spoken to wants to see us succeed. So as an example, this afternoon I'll spend 2 hours on the phone with the CIO of the Mayo Clinic, the CIO of Partners Healthcare, the CIO of Johns Hopkins and Kaiser Permanente. And they will be providing feedback, on they're reviewing the contract, they're taking a look and saying, hey, here are some of the things that we would do differently, providing us feedback and helping coach us. As I've reached out to various
Very good. I yield back.
This time I'd like to recognize the gentleman from California for 5 minutes, Mr. Maldeo.
Thank you, Mr. Chairman. Thank you, gentlemen, for appearing today. Personally, I'd like to applaud your decision to adopt the same electronic healthcare system as the DoD. Obviously, for nearly 2 decades, the VA has been seeking to achieve this interoperability between the VA and VA's Vista and the DoD system. But it makes much more sense to me if both DoD and VA utilize the same system. There has been some debate recently about a veteran's lack of ability to access their personal health care information. Do you foresee in the transition the establishment of a secure, patient-centered, portable medical record system that a veteran can access their own comprehensive medical records? This is something that has been available to the private sector for quite some time, so it's only natural we afford the same ability to our veterans as well.
Yeah. Well, I may ask one of my colleagues just to chime in with the detail, but our system now, My Healthy Vet, is used by millions of veterans. It is a portable system where they are able to access and message with the providers, used probably more extensively than any other system in the country. So we believe in that. We think that's important. The transition of that over to Cerner, maybe I'd ask Mr. Windom to talk about.
I mean, I'll defer to Mr. Blackburn, but I can say simply, yes, mobility, the ability to access your record via your phone, via web-based access, definitely at the forefront of the terms and conditions of our contract, and that we're pursuing all of the state-of-the-art technology that commercial environment can produce. So, Mr. Blackburn, I'll pass to you.
I agree, and you know, as an example, I think I'm personally a good example. I'm a veteran, an Army veteran. The DoD has a part of my healthcare record. I got out of service, moved back to my hometown of Boston, where Partners Healthcare had part of my. I then moved to Cleveland. Cleveland Clinic has part of my healthcare. When I came to the VA 3 years ago, I enrolled in VA healthcare and get my care right now at the Washington VAMC Orange Clinic. I also get care in the community. Every single one of, I think I just named about 5 different people that have different pieces of my medical record that right now are not shared well. When I had to print out my Cleveland Clinic records and give them to my VA doctor so that he had them. My VA doctor does use the Joint Legacy Viewer, but I got out in 2003, so not much is in there. My records were destroyed in a flood. With that, the ability for a veteran or a citizen to be able to get those pieces and put them together is something that's coming, and we're very excited that this will begin to facilitate that process by linking DoD and VA, and with the Digital Veterans Platform beginning to link in all these other systems as well. It will take a little bit of time to get to where we are going to be in 10 years, where you're going to have this all together on your iPhone, but we're taking the first steps to get there.
All right, then I'm going to go the opposite direction, because obviously access means that there's an issue with security. So, Mr. Secretary, one of the issues I have focused on in my career, and my actual first piece of legislation ever signed into law, had to do with securing someone's ID and their personal information. Government agencies have to take steps to protect people's personal information. Can you speak to the cybersecurity enhancements the VA is undertaking in this transition? And this system will obviously contain the very sensitive personal information of millions of veterans. What is the department doing to ensure the safety of that information?
Yeah. Mr. Windom, do you want to talk about the cybersecurity requirements in the contract?
I'll touch on, and then I'll defer to Mr. Blackburn again, is that I come from the DoD side of the house, and you know, the OI&T efforts right now are leveraging fully the security posture of DoD. And so, and I can assure you the level 2, 3, 4, 5 certifications that exist within the framework of DoD security posture are being adopted fully. We just had a session with DoD to highlight the importance of us, the reciprocity agreements that would be necessary between VA and DoD in order to leverage their posture fully. Those are being consummated as we speak. So it's not going to be this separate VA security posture, separate DoD. There's going to be a joint security posture that is going to support the transition of a soldier, sailor, airman, Marine from the active duty environment to the veteran environment. So that is of the utmost importance to us. Mr. Blackburn?
Yeah, I share your concerns on cybersecurity. The VA does not have a great track record. I think we've been on the GAO high risk report as a material weakness for 16 consecutive years, which is a streak that we are not proud of. But I am proud that we've made great strides over the last 2 or 3 years, and we've gotten good feedback from GAO and OIG on that. I think one of the reasons we have been so vulnerable is having these 130 instances on an antiquated system. So this will help that out, but in the future we will be looking at new emerging technologies, whether it's blockchain or whatever it might be, to get that even more secure.
I just feel that the transition period is something we need to be very careful with. Yes, so my time is up, and thank you very much.
This time I'd like to recognize the gentleman from Nebraska for 5 minutes, Mr. Fortenberry.
Gentlemen, good morning, Mr. Secretary. Nice to see you. You have an extensive background in healthcare management, running facilities, being an entrepreneur. If someone told you this was going to take you 10 years before an implementation of an interoperable system in one of your hospitals, you'd find that absolutely unacceptable. Now, this is a big, massive project that a lot of the difficulties, or put more succinctly, mess you've inherited. I get that, but this has been going on for a very long time. So let me just try to simplify this so that I can understand, and perhaps we can unpack a lot of this technical language. But I have about 4 things I want to get to, including Nebraska's, some issues of late in Nebraska. You have a system now where you're on one screen, you can show DOD records and your records, right? That's interoperability at the moment. This is going to be combined so that one button pulls up everything from a former service member's life, right?
Yes.
Okay. Why 10 years? I very much appreciate what you're saying, that we're getting out of the software business, because why would we build out the expertise in that area when that it's not our expertise? You want to deliver care. I get that. Why 10 years? What do you expect the outcome to be? Are there progress measures along the way so that in another year the system's not going to say we've got another significant delay and it's 2 more years? Let me throw everything out on the table first, and then I'd like you to get to it. We have some information that the VA has always worked with the Indian Health Service to help them with their electronic medical records, but there is some indication that you may desire to move away from that. I'd like your comment on that, because that's some slippage that may cause significant difficulty for another part of government that we would not like to see. Finally, there's a glitch in the outpatient clinic contract in Lincoln. Give me your assessment of that situation and explain the criteria for site selection, because I think there's some murkiness there that has caused some possible confusion. Then I have hopefully an answer to all of your problems if we have enough time.
Okay, I'd like to hear the answer. Sure you don't want to start with the answer? Look, I think the implementation is frankly 18 months. From the time we sign the contract till we get our first site up is 18 months, which is consistent with a private sector practice in terms of from contract to full implementation. We will begin to, after that first implementation, start shutting down what will be 130 successive implementations after that. So by the time we reach all of our facilities across the country, which are around 1,600, but 130 different systems control those 1,600, it will be around 8 years after the first 18-month implementation.
So after 18 months, what % of systems will have successful interoperability?
Well, we'll start with one.
But what % of veterans does that represent?
Well, that would be a very small % of veterans. But what we have is a detailed project implementation timeline, which we'd be glad to share you how we get from one system in 18 months all the way through.
That's not really necessary. You understand the nature of the question. Obviously, you're going to try something to make sure it works, but the larger number of veterans that's going to actually be served as a priority would seem to me to be a prudent way forward.
Yeah. The longer we take to implement this,
yes, sir.
The longer we take to implement this, the more costly it is and the greater we think that the risk is to veterans. So we are trying to do this as aggressively as we possibly can.
But time's running short. I'm sorry. Can you, in 30 seconds, address the Indian Health Service question?
The Indian Health Service does use our VISTA system. That will remain available. This is a open source system. We won't withdraw that from them. They may have to look at alternative systems just as we are, and we'd be glad to work with them on that. We have no desire to hold that to.
We don't want to put them in a situation where they're having to go out on their own and redesign an entire system. So anything they can leverage from your experience would be most helpful.
Can I touch on that, sir?
Yes.
So we've been in communication with Indian Health Services, and we are firmly committed to supporting.
Great, thank you. I'm sorry to interrupt. Time's ticking down.
And Lincoln, Nebraska, we will get back to you on that. But that was a small business issue in terms of the award where we've had to go now back out for contract. We're committed to that contract. It is off schedule because of the small business issue, but we can get back to
as we've discussed before. A lot of very creative public, private.
Yes.
We just need for this to move and move quickly because there's a lot on hold.
I will follow up with you.
Thank you so much.
Thank you, Mr. Fortenary. Before we move into the closed session, which we'll have in a moment, some members can ask additional questions. I did have 2 questions I felt needed to be asked in open session to the Secretary. One is, what is OMB's commitment to this entire project? We noticed that OMB has not submitted an FY18 budget amendment as it did for the Department of Defense. I think that's very important we establish that in the open session.
Yep. As you know, we've been working very closely with OMB, just like we've come to you and asked for your assistance, and they are both aware and supportive of this initiative.
And there's one final question. Mr. Secretary, you and I have joked that neither of us will be in the jobs we currently hold in 10 years. But in a serious vein, I'm concerned that without consistent leadership, this expensive project could be derailed or reconfigured given the long implementation time. We've seen the electronic health record whipsaw back and forth every time a new secretary or a VA or DOD comes to the scene. Is it a fair concern for the committee that this health record won't be able to withstand changes in political leadership or budgetary shortfalls?
Well, first of all, if you commit to stay, then I'll consider that too. So, but no. I think that it would be once we step in this direction, and I think as all of you have really reflected, this is the right thing to do. This is the right thing that should have been done years ago. I do not believe this is going to be subject to political back and forths, and we're going to set this up in a way that when we start this, there's the full commitment, and while anything could happen, I don't believe that this is likely to be derailed.
Thank you.
Mrs. Lee wants one question.
Okay. Well, I was going to ask Mrs. Lee to ask a question in open session, and then members will have a next round in closed session. So anything you want to ask, you can ask in there.
Okay, thank you very much. Just want to find out who's going to maintain this system once the new system is rolled out and fully implemented, and what's going to happen to VA employees maintaining Vista once the Cerner system is rolled out, and will they move over to the new Cerner system?
Yeah. The basic upkeep and modernization of the new system is going to be done by the Cerner Corporation. That's the whole point of us getting out of the software development system. Our current employees, we need every one of them. These are it's very rare to find software engineers who know MUMPS, which is our system which started back in 1977. But they will, we want them to stay. We need them to stay over this implementation period, and any staff, once we shut down the Vista system, will be utilized as part of our current IT software, part of our infrastructure needs. So
no job loss.
We do not believe this will be a job loss.
Thank you, Mr. Chairman, very much.
Thank you, Ms. Lee. And then, at this time, I think our members had a good opportunity to ask questions about the electronic health record in the public setting. We will now adjourn and move to closed session so that members may discuss with the Secretary issues that could compromise contract negotiations if discussed publicly. We ask members of the public at this time to leave the room. Associate staff members, committee staff, VA staff, and our court reporter, of course, may stay. So with that, we'll adjourn and go into closed session. That includes the press.